Okay, I'd like to have your attention. We're going to start our last lecture of the afternoon. And I'd like to introduce Ashley Teusink, and she is a bone marrow transplant clinical specialist at Cincinnati Children's Hospital in Cincinnati, Ohio. She completed her PharmD coursework and earned her doctorate of pharmacy at the Medical University of South Carolina. She also earned her master's in business administration at the same time at the Citadel in Charleston, South Carolina. Ashley then completed 2 years of residency training, specializing in pediatrics with an emphasis in hematology-oncology at the Medical University of South Carolina. In August 2010, Ashley completed her residency and started as a clinical specialist in our hospital at Cincinnati Children's, where she remains there today. She's the lead PharmD for the program, and I'd like to introduce Ashley.
Thank you so much. I'm excited to talk to you today. I'm sure some of you may be disappointed hearing that I'm from South Carolina. I have all these schooling in South Carolina. I don't have a Southern accent because I'm not really from South Carolina. I just did all of my education there, so sorry about that. I'm excited to speak to you guys today about the role of a clinical pharmacist on the bone marrow transplant team. When I was asked to do this, I thought, well, how the heck can I fill up 45 minutes just telling about what we do? But what I ended up doing was adding at the end some dosing recommendations and just dosing considerations in special populations. So I have no conflicts of interest to disclose. So the learning objectives for this next 45 minutes or so will be to describe the education and training requirements of a clinical pharmacist, to explain the role of a clinical pharmacist as part of the multidisciplinary bone marrow transplant team, and finally to identify those patient populations where non-standard dosing may be utilized. And this is one of the roles a clinical pharmacist can help you with, helping with the dosing in those non-standard patients. So what is a hospital pharmacist? I found this slide and I think it's pretty accurate. So what my mom and dad think I do, they think I'm a retail pharmacist in the community setting, counting pills, dispensing medications. My mom even bought me a coffee mug that said, I'm a pill counting by 5, drug-loving pharmacist. I'm like, well, that's not what I do at all, but okay, thank you for the coffee mug. What the nurses think I do, we kind of disappear back to our offices after rounds. So, they don't know what we're doing in the afternoon. For all they know, we could just be sitting around drinking tea and hanging out. What my friends think I do, they don't really know either, but they think, I make a lot of money, which is not true, but I think they may think because I wear a pager a lot of times that maybe I have some extracurricular activities going on. What physicians and prescribers think I do. I have this lady here, I don't know if she's a grandma or a teacher, but she's very stern. A lot of times clinical pharmacists are the person that have the role of enforcing the formulary, or in the times now, telling you what drugs you can or cannot have because of shortages, and then ultimately pharmacists have the final verification of order. So a lot of times providers see us as a person who just stops them from doing what they want. Of course, what I think I do, I think I save the world, right? If it wasn't for me, these patients wouldn't live, rounds wouldn't happen, that sort of thing. But in reality, what I do after rounds is I spend a lot of time on my computer, reviewing patient labs, reviewing levels, doing research, working on policies, and that sort of thing. So we don't have those great audience response gadgets, but we're going to do it the old-fashioned way. So just by a show of hands, do you have a bone marrow transplant pharmacist as part of your multidisciplinary team? Yes, no, or I don't know. So for those of you that do have one, raise your hand. Awesome. So I think just about everyone. Is there anyone that doesn't have one? Or anyone that doesn't know? Okay, part-time. So there's sometimes they probably have other commitments within the hospital, or maybe a shared position with general pediatrics, or a different role. So for those of you that answered yes, how many does this clinical pharmacist take part on your daily rounds? So just by a show of hands, yes, if your pharmacist does take part. Great. And then those of you who have a pharmacist but they don't take part on rounds? Okay. So I went ahead and asked my colleagues, too, through the ASBMT listserv to kind of see what other practices are doing. Well, I guess I'll get to that in a minute. So we'll first start with education. So since 2004, all pharmacy programs are now a 4-year doctorate program. When a graduate finishes, they earn a doctorate of pharmacy or a PharmD degree. There are several ways to earn this PharmD degree. The two most common are a 5 to 6 non-traditional program. So they're programs where you enter your undergrad, you go ahead and declare that you want to be, earn your PharmD, and then they put you in essentially no summers off, no time off, you just go straight for 6 years, and at the end of the 6 years, you earn your PharmD, but you've also earned an undergrad degree in there too. There's the way I did it, the more traditional route, where you do a full 4 years of undergrad, and then go ahead and do four full years of your doctorate program. After that, most of the clinical pharmacists you're working with have completed at least 1 year of residency. So I went ahead and surveyed my colleagues through the ASBMT listserv to kind of find out what education they had just to be representative of the actual BMT department. So you can see the large majority of our clinicians have a combined 6 years of undergrad and PharmD program. So they did that accelerated program where they went 6 years straight. About 22% kind of did it my route, the four years of undergrad and the 4 years of the PharmD program. There's 27% or so that did other, and really when I looked down at and how they broke that down, a lot of them did their undergrad and didn't maybe earn a degree, so completed 3 years of undergrad, getting all the prerequisites for their PharmD program, and then went ahead and transferred to a PharmD program. Some of these were also people too who had earned a BS in pharmacy, which was our older degree, and then went back and got a PharmD later. So they did a 5-year Bachelor of Science in Pharmacy, and then went back and got their PharmD. And then, of course, the small minority did a combined 5 years, just receiving their BS in pharmacy and never went back to get their PharmD. I asked how many years of residency training the BMT pharmacists had. You can see 60% had at least 2 years of residency. 22% had 1 year of residency. There's only a small minority out there who had no residency training. You'll see, I think, as the years go on, that we'll see more and more clinicians with 2 years of training, and probably will go away from seeing any clinicians that don't have any residency training. The 5% that have other, they usually went ahead and did a fellowship too prior to coming and taking their position as a BMT pharmacist. Okay, that's great. They have all this education. What do these pharmacists actually do? The roles and pharmacy models vary drastically from institution to institution. The University Health System Consortium identifies the following services as essential services to be performed by clinical pharmacists. So the reconciliation of medications upon admission for patients admitted as inpatients. So although they may not be listed as the formal person responsible for a med rec, every pharmacist should look at the medications when a patient is admitted and do an informal, at least medication reconciliation. They should reconcile medications within transitions of care, so when patients are transferred to the ICU, go to the OR and come back. They should develop individualized treatment and monitoring plans for patients, review all non-emergent orders prior to the first dose administered, monitor patient medication profiles daily, participate in patient care rounds, which is great because the large majority of you have said you do have a pharmacist that participates in rounds, educate patients on new medications. So a lot of centers prior to a patient starting their preparative regimen will sit down with them and discuss all of the medications they're going to receive in their preparative regimen, as well as any supportive care and GVHD medications they're going to be receiving. And then, of course, counsel high-risk patients at discharge, which is all BMT transplant patients. So I continue to survey my colleagues. I asked them how many practiced in the inpatient or outpatient setting. And you can see that the large majority are established in an inpatient setting. We are starting to branch out and see more clinicians in the outpatient setting. And then about 20% actually participate in both inpatient and outpatient settings. Do you participate in interdisciplinary rounds? As reflected by you guys, 93% of our clinicians do participate in interdisciplinary rounds. Are you responsible for order verification? So this is about half and half, as you can see. So a lot of pharmacists will enter the orders, and then there'll be a different type of pharmacist, perhaps a decentralized pharmacist or what we call a central pharmacist, depending on the model, who will actually be the one to verify orders. That's actually how it is at Cincinnati Children's Hospital, which I kind of like because I feel it's like a double check to any recommendations I make. But there are plenty of pharmacists who do go ahead and participate in interdisciplinary rounds and then verify their own orders. Do you perform discharge counseling for patients? Again, 3/4 of our clinicians do perform discharge counseling for our patients, which I think is extremely important because this is a high-risk population. So then I just wanted to see how many of our colleagues were active in research, and you can see that almost 70% of the BMT pharmacists do participate in research-related activities. Also, a large majority, or at least half of the pharmacists have some activity in writing TPN, whether they're assisting the primary clinician, the provider, or the dietitian in writing the orders, or whether they're fully responsible for writing the orders. Is that it? No, usually after rounds or, in their afternoons, in their free time, pharmacists are participating in guideline development, participating in policy and procedure development and revision. They're assigned to hospital-wide committees, usually P&T, nutrition support. They're involved in research and scholarly activities. They're responsible for the education of students and residents. Many respond to maydays and codes, and of course they're responsible for the evaluation of the current medication use. And again, in this new era, they're largely responsible for helping establish new guidelines in the face of shortages, which we know is all too common. So I just wanted to illustrate what a typical day was like for me and my pharmacist that I work with. So we usually arrive to work around 6:30. We settle down in our little cubicles and we're looking up the patients, following patient labs. We carry around these big books, which our physicians refer to as Harry Potter books, because they contain everything you could ever want to know about the patient. So we haven't converted fully to electronic, at least our service pharmacy doesn't. From 8 to 12 or later, depending on which attending is on service, we can be found on the floor rounding. We do participate in interdisciplinary rounds, and at the end of them, we do write and order parental nutrition with our dietitians. Our afternoons can be comprised of many activities. Oftentimes you feel like the Tasmanian devil because you're trying to do so many things. So we can follow up on any ongoing issues with our patients. Of course, we follow up on drug levels and make recommendations, discuss those with our physicians and our nurse practitioners and residents, and make recommendations for change. We work with our care coordinators and our providers to help coordinate the discharge of patients. We perform discharge counseling on all new discharges. So after a bone marrow transplant, the first time a patient's been discharged, we always perform discharge counseling. We are actually responsible for entering and verifying chemotherapy orders. So our physicians still write their chemotherapy on paper and double-sign paper orders. We then, as pharmacists, take those paper orders and enter them in Beacon, double-check them, and then send them back to our physicians through Epic to be signed and released. Of course, we have many committees and meetings to attend. We can educate our students, respond to provider questions as they call our page. I often joke that our little office is like the Jerry Lewis telethon in the afternoon. We're always getting calls. Phones are always ringing. We provide drug information services. It's one large part of a pharmacist's education is just really mastering drug literature searches. So we're able to provide those services to all of our clinicians. Perform research, work on guideline and policy development, and of course respond to code situations if they occur. I also provide 24/7 on-call services, which I know some of your pharmacists do too. So, here I am right here with Khloe Kardashian and Lamar. You can see we're having dinner, but I've got my pager with me. Here I am doing a side plank, and I've got my pager close to my hip. You guys know none of these are me. And, we even sleep next to our pagers. So we're always there for you guys if you need us. So as I said, that's a brief introduction into what your clinical pharmacist does. But, one other thing that we can be really useful for, I feel like, is drug dosing in special populations. So those non-standard patients you're seeing. While there's several special populations I could discuss, the ones I really wanted to focus on were organ dysfunction, so both renal and hepatic dysfunction, drug dosing and obesity. Unfortunately, this is becoming an increasingly, a growing problem, I guess you could say. Plasmapheresis, that's an area that we're still discovering really what our medications are doing and how we're dosing them in regards to plasmapheresis. And then I think another new area we're seeing is based on pharmacogenetics and genomics. So just to start off, drug dosing and organ dysfunction. So I started off with a case here. RJ, he's our 25-year-old patient. He's status post-bone marrow transplant, and he's hospitalized for febrile neutropenia. His creatinine clearance is estimated to be 33 milliliters per minute per 1.73 meters squared. His cultures are currently positive for gram-negative rods. He started on meropenem and tobramycin for empiric coverage. So which of these statements is true? I'll go ahead and let you read through them, and then we'll do another show of hands since we don't have those ARS devices. All right, so how many of you think although both drugs have significant renal elimination, RJ's creatinine clearance is not bad enough to adjust any medications? The tobramycin is eliminated renally and will have to be adjusted for RJ's creatinine clearance. However, meropenem, you can just keep that dose the same as standard dosing. Okay. Both drugs have significant renal elimination and will need to be adjusted for RJ's creatinine clearance. Good. And then neither drug will need to be adjusted, because neither have significant renal elimination. Great, so at least both of, it seems like everyone in the room recognized tobramycin is eliminated renally, and it also is a drug that we say has a narrow therapeutic index, so the margin of error is small, so there's only, a certain concentration, a small window of concentration between when you're actually providing efficacious dosing and when you're crossing that line into toxicity. So I think everyone recognized that would have to be renally adjusted and levels followed closely. And then at least half of you recognize that meropenem would also be dose adjusted. So that's good. So the answer is C. So as you guys are probably aware, many drugs are eliminated by the kidneys. Some drugs are actually converted into active metabolites that are dependent on the kidney for elimination. And patients with renal dysfunction, then obviously these drugs that are eliminated can accumulate. And just a good, a little standard you can think of is if you're looking at the pharmacokinetic properties of a particular drug and at least 30% is eliminated by the kidneys, then you can go ahead and mark that as something that probably has to be renally adjusted in the case of renal dysfunction. And then, obviously, the reason you want to dose adjust it is just to reduce toxicity. And as I said, your precision and your accuracy of adjustment really depends on the therapeutic index of the drug. So something like tobramycin, you definitely have to monitor extra levels. With meropenem, you do have accumulation in renal toxicity or in renal deficiency, but your risk of toxicity probably isn't as high as it would be with gentamicin or tobramycin, your aminoglycosides. So as far as estimating renal dysfunction, for our adult clinicians out there, the gold standard is the Cockcroft-Gault formulation, which I have listed right here. We do see use of the MDRD equation too, and as I'll discuss later, that may be more appropriate in obese patients. For pediatric clinicians, we use the original or the modified Schwartz equation, which I have listed here. At Cincinnati Children's, we often rely on our cystatin C too. We know in our bone marrow transplant patients, sometimes creatinine is not a good marker for their renal function just because of the deconditioning our patients have experienced. So I'm just curious how many other centers out there use cystatin C as a marker for renal function, if anyone. Okay, good. And that, of course, has its own problems with it, too. If our patients are on steroids, we know that can make the cystatin C high or underestimate the GFR. So we always have to keep that in mind, too, when we're using cystatin C as a marker of our renal function. So additional challenges, of course, present themselves when these patients with renal dysfunction are then started on hemodialysis or hemofiltration. The amount of drug removed may require actually supplemental dosing. So, and that also depends on the modality, whether they're getting intermittent hemodialysis or continuous. So whether it's CVVHD, CVVHDF, that'll all play a part into what, if any, supplemental dosing we'll need to give. Other things that will determine what kind of dose we need to give will be the properties of the drug itself. The filter properties of the mode of dialysis you're using, and also the ultrafiltration flow rate. So in particular, drugs that have a large molecular weight, so your bulky monoclonal antibodies, a lot of times aren't removed by dialysis, so you don't have to worry about them as much. And I wouldn't say, blanket, don't worry about monoclonal antibodies, but the really bulky ones with a large molecular weight, they're often too large to be removed. The volume of distribution. So this is just tells us how well the drug distributes throughout the body. Drugs that have a large volume of distribution actually get into tissue, where drugs that have a small volume of distribution stay in the intravascular space in the serum. So you are less concerned with drugs that have a large volume of distribution, that they're going to be removed during dialysis, than you are for drugs that have a small volume of distribution. So for example, your aminoglycosides, again, have a small volume of distribution, so they are likely going to be removed by any mode of dialysis. The water solubility, that kind of goes hand in hand with the volume of distribution. Drugs that are more water soluble usually have a smaller volume of distribution, where drugs that are lipophilic have a larger volume of distribution. So drugs that are highly water soluble will be removed by dialysis. And then protein binding. Drugs that are highly protein bound, such as phenytoin, they will not be removed by dialysis as easily as a drug that has a large concentration of free drug. The filter properties are also important. So the larger the surface area of the filter, the greater removal you're going to have of drug. And then also, as you increase your ultrafiltration or flow rate of your dialysis, you're also going to increase your drug removal. So the second organ dysfunction we'll look at is your hepatic dysfunction. So impairment of the liver function may alter different aspects of drugs' pharmacokinetics. It can alter your absorption. So you guys hear a lot probably the bioavailability of a drug. If the bioavailability of a drug is really low, that generally means that there's high first-pass kinetics or high hepatic extraction once a patient takes the medication. If your liver isn't working, you're not going to get that high rate of hepatic extraction, and therefore there's going to be increased bioavailability of the drug. So you could possibly experience toxicities because there's more drug that is actually making it into the patient's bloodstream. As far as distribution, the volume of distribution can change for a couple of reasons. If you get ascites with your hepatic dysfunction, as we know can occur, then that's going to increase your volume of distribution. As far as albumin, with hepatic dysfunction, there's decrease in synthesis of albumin. So you have decrease for those drugs that are highly bound to albumin, again, to use phenytoin as an example. They're not going to have all the binding places they need to, so there's going to be increased free phenytoin, which just makes the monitoring of phenytoin even more important, phenytoin levels. But I will caution you, when you're ordering phenytoin, there's two levels you can always order. There's a total phenytoin level. That won't change. What you would need to order in patients with hepatic dysfunction is your free phenytoin level, because that's going to actually monitor the amount that's not bound to albumin in the blood. There are equations, too, that you can correct for low albumin. And then finally, metabolism and elimination. A lot of drugs are metabolized through the CYP-P450 enzyme system. And if your liver isn't working, then those enzymes aren't being produced and they're not able to metabolize drugs. So specifically, drugs like etoposide need to be dose reduced in liver dysfunction. Then gemcitabine, there are some, we know it's metabolized by the liver, but there's some case reports and case series showing that it's okay to continue full dosing of gemcitabine despite liver dysfunction, but that's an area of continued interest. So to assess a patient's liver function, one of the best ways to assess it is to use the Child-Pugh score, and I have it listed here, but it really assesses 5 markers: the patient's bilirubin, the patient's albumin, prothrombin time, amount of ascites, and presence of hepatic encephalopathy, and they get a score for each one of those categories. Based on their cumulative score, you can assign them a Child-Pugh class A, B, or C, and this can be used because this is what a lot of drug manufacturers use to tell you how to dose reduce. They're going to say, if your patient has a Child-Pugh score of B, then make this sort of dose reduction. So it's always important, if you do have a patient with hepatic dysfunction, to go ahead and try to calculate their Child-Pugh score and then see if there's recommendations based on that score. So in general, with hepatic dysfunction, you want to avoid medications that undergo significant hepatic metabolism. So, you can just pull up one of your references, your tertiary references, LexiComp or Micromedics, and just see the amount of hepatic metabolism that it undergoes. If it is a large amount, then you may want to consider using an alternative agent in that same class. Calculate your Child-Pugh classification score, as we just discussed in the last slide. And then if you're able, start low and titrate. So this really refers to more of our benzos and our opioids. It's always a good idea to start slow or start low with those and titrate slowly till you reach your therapeutic effect. And finally, you can always call your clinical pharmacist and say, "Help, what do I do?" And hopefully we'll be able to help you. So the next area I wanted to cover was drug dosing and obesity. As I mentioned, this is becoming an increasingly area of interest for many clinicians, and a lot of that is just because of our population is growing. We are seeing an increased number of obese patients. So to define obesity in adults is defined as a BMI greater than 30. In children, it's a BMI that's greater than the 95th percentile for children of the same sex in age. So if we look at adults, and one of the most recent surveys by the CDC, obesity among adults is up to a rate of 33.8%. And if we look at obesity or overweight, 68% of our population qualifies as being obese or overweight. In children, and this is kind of confusing if you think about it, 11.9% of our patients have a BMI greater than 97th percentile. So, and then 16.9% have a BMI greater than the 95th percentile, and 31.7% have a BMI greater than the 85th percentile. So you may wonder, why haven't we shifted our growth curves to, really reflect what our pediatric patients are today? But the CDC and World Health Organization have actually made the decision, which I think is a good one, not to shift our growth curves to reflect what we are currently, representing as the population, but rather to represent what is the healthy population. So that's why 11.9% of our patients are greater than what used to be the 97th percentile. So when you're thinking about drug doses, a lot of times you'll hear terms such as ideal body weight or adjusted body weight or total body weight, and I'll get to those definitions on the next slide. But one of the first things you need to be able to do is to calculate the ideal body weight or lean body weight for your patient. So in adults, I have the equations here, and then also those equations for pediatrics. But again, that'll give you a starting point to say, what should my patient weigh? Or where in the 50th percentile for kids would our patient fall? So then just to define the different categories, lean body mass is described as a non-fat cell mass and intracellular connective tissue. It accounts for more than 99% of the body's metabolic activity. Ideal body weight is the surrogate marker for above, and I showed you the calculations you can use to calculate your ideal body weight. A dosing weight is this created weight or category, and it's often referred to as adjusted body weight as well, but it's usually a percentile of the total body weight. So it's somewhere between the ideal body weight and the total body weight, and a lot of times what you use as your adjusted body weight depends on the characteristics of the drug, depending on how well it distributes into fat or whether it stays, has a small volume of distribution and stays in the intravascular space. And then total body weight is just the weight you see when you step on a set of scales. Not the weight we put on our driver's license, but the true weight when you get on a set of scales. So the reason that drug dosing in obesity can be different than in a person that weighs their ideal body weight is because the lean body weight is increased. So not only total body weight is increased, but also lean body weight is increased. Then we also know adipose tissue is increased. So especially for those drugs that have a high volume of distribution and are distributing into fat, there's going to be a bigger volume of distribution. There's altered hemodynamics, altered glomerular filtration rate, and that's just the thought behind that is it's a bigger surface area. Altered liver function, and also changes in the concentration of plasma proteins. So I'm going to go in a little more depth in how this actually affects each step of the pharmacokinetics of drugs. So absorption, because there is increased body surface area, there is thought that theoretically this could increase the amount of drug that's absorbed because it's more surface area on which drug can be absorbed. But it's not really shown to be clinically relevant yet. Probably one of the biggest areas where we do think it is clinically relevant is distribution. So with increased adipose tissue mass, it can actually influence medications, like I said, that have the lipophilic properties. Increased organ mass, lean body mass, and blood volume in obesity also affects hydrophilic medications. So just to compare and contrast these two, if we think about propofol, it's a highly lipophilic drug, so you're going to actually probably want to dose on total body weight for propofol because it's going to distribute into those fat stores. If you think about something like tobramycin or aminoglycosides again, it's a hydrophilic medication, so for those drugs we actually use an adjusted body weight, so somewhere between the ideal body weight and the total body weight. As far as metabolism goes, it is also affected. So not necessarily our phase 1 metabolism, but our phase 2, so our glucuronidation and conjugation of drugs. And then as far as elimination goes, there's been shown that there's increased clearance of medications in obese individuals, and again that's thought to be due to the increased surface area and therefore increased GFR. And then as I mentioned, because of this, they don't really think the Cockcroft-Gault equation measures creatinine clearance appropriately in lean patients, so that's why there's been some advocates for the MDRD equation, which I showed you on the earlier slide. That may be a more appropriate measure of an obese patient's true creatinine clearance. And then, of course, other things to consider are things like the cystatin C. Sometimes in obese patients, I would recommend, calculating their creatinine clearance by the Cockcroft-Gault, calculating it by the MDRD. If you have the ability to, then maybe getting a cystatin C too, and looking at all three markers, and coming up with what a good estimate of their creatinine clearance would be by looking at all three of those. There was actually a really good article published just at the end of last month, at the end of January, looking at conditioning chemotherapy dose adjustment in obese patients. So you can see it's a pretty good review and position statement by ASBMT, actually, the practice committee, looking at various chemotherapy agents. I encourage you all to look at this. Just to give you a kind of a spoiler alert, drugs that we commonly do adjust for obesity are drugs like etoposide, cyclophosphamide. Busulfan is one that is recommended to be adjusted for obesity, but how many of you send off your busulfan, give a test dose or give a first dose and send off for busulfan kinetics, just a show of hands? Right, so that kind of eliminates that situation or that problem, right? Because you're going to send off your first dose, and then that's going to take into account too the obesity of the patient and the weight of the patient to help you give a good dose back, an appropriate dose back. So drug dosing and plasmapheresis. I know at our center we're using this in combination with bortezomib to look at donor-specific antibodies, or to remove donor-specific antibodies, and we're also using it for treatment of TMA in conjunction with Soliris. And that's been great because it's been therapeutically effective for a patient, but it's also posed the issue of, well, what do we do with the other medications they're receiving? How does plasmapheresis actually affect this drug? And this is an ongoing area of research and an area that we need a lot more information in, but because it is being a modality that's being used more often, we are seeing some studies and some reviews where essentially they're just taking case reports from here and there, and interestingly, a lot of it comes from toxicology reports too. So when a patient has been received an overdose of a particular medication and plasmapheresis has been used to try and remove the drug, that's where a lot of our literature comes from. So elimination by plasmapheresis is a passive process, and it can actually be described with linear kinetics. Owing to its ability to remove plasma exchange can remove circulating drug from the plasma compartment. It's, again, so similar to what we talked about earlier, the volume of distribution of the drug plays a big role into whether it'll be removed or not. So drugs that have a low volume of distribution, like our aminoglycosides, they're removed by plasmapheresis. Those that have a high rate of protein binding, which is opposite than we think of dialysis, are also removed. So again, there comes our gold standard as far as protein binding goes, phenytoin. Again, like I said, there's not a lot of information about a lot of medications out there. So I always say, when in doubt, try to give it after plasmapheresis, whatever the drug is, if you're able to do that. As far as some of our GVHD drugs, both tacrolimus and cyclosporin have not been shown to be removed by plasmapheresis, so that's a headache avoided, because you can imagine if we were giving intermittent plasmapheresis, our levels would be all over the place and we'd be chasing those. On the contrast, rituximab and vincristine have both been shown to be removed by plasmapheresis, so that's just something to consider. I encourage you, if you have patients that are receiving plasmapheresis and they're, either experiencing, or you're not seeing the therapeutic outcomes you think you should be receiving from that patient, consider plasmapheresis removal by plasmapheresis. That's one of the factors you're not reaching your therapeutic goals. And I also encourage you to publish any case reports, with any experience you have for these drugs, because like I said, it's just an area that we just don't know a whole lot about. And you'll see a case report, for instance, there was just a case report on voriconazole and it not being removed by plasmapheresis. But I can tell you from my own experience that when we've had patients on plasmapheresis, we've had an impossible time reaching therapeutic levels. So I just think this is an area of ongoing research and an area where we really lack a lot of knowledge. I did include up here one really good article for you that I encourage you to take a look at. It's probably the best review out there that we have thus far. I want to say it has at least 40 drugs in there, but it also reviews those things I talked about, the characteristics of different drugs that would make it susceptible to being removed by plasmapheresis or not. And then again, I just encourage you, if you have any information or you're using this in your center and have experience, to publish that. The next case, the question you guys probably have is, well, what about photopheresis? We're not going to even go there. There is even less literature with photopheresis than we have with plasmapheresis. Again, there aren't even any good reviews with photopheresis. It really comes down to those who have had experience and are willing to publish their experiences as in the form of case reports. So I think this is another area that's growing and increasing in curiosity, and it's an area that I'm particularly interested in. So if we look at pharmacogenomics and drug dosing, we know that genes encoding for drug metabolizing enzymes were some of the first that were shown to be polymorphic. Again, I mentioned so many of our medications are metabolized through the CYP P450 enzymes, and we have shown that some of these are highly polymorphic. So we know that our CYP2D6, our CYP2C19, and our CYP2C9 all possess different polymorphisms of alleles that could lead them to either being non-functional, slower function, so they have one copy of a functional allele, but they don't metabolize drug as a person that had two functional copies of an allele would. And then there's even those patients that are ultra rapid metabolizers, so they have a polymorphism that actually encodes for an enzyme that, to put it simply, works extra hard and metabolizes even more drug than a standard patient. So, it's this variation in enzymes that really helps us understand why there's so much inter-patient or inter-individual variability in our dosing. We do a lot of work at Cincinnati Children's looking at voriconazole and the polymorphism and how that impacts the dose required to reach target range. But you're also seeing a lot of research in the area of tacrolimus and cyclosporin, so I assure you that those are on the horizon as well. I also think, busulfan often could be an area of interest, but we've pretty much nailed down that we're just giving one dose and sending off for PK studies, so we don't need to do that upfront identification of the polymorphisms to determine the dose. Kind of covered this, but there's different things that lead to these polymorphisms. So a polymorphism can be a polymorphism that results in an altered splice site, a frame shift mutation, or a complete gene deletion, and that would result in a non-functional allele. As long as you have just one copy of the non-functional allele, you will maintain some activity, but you'll probably just metabolize drugs slower. There's changes in amino acid sequence that can alter the catalytic activity, and those are generally those enzymes that have ultra-rapid metabolizing quality, so they metabolize drug at a quicker rate. And there could be copy number variation, and again, this can lead to substantially increased drug metabolism, which leads to therapeutic failure. Here's a whole list of the various different polymorphisms that have been identified. I know you can't read that, and that's kind of purposeful, because the one thing I want to caution you on is there are a lot of polymorphisms that have been identified, but they're not clinically relevant. In order for a polymorphism to be clinically relevant, you have to think about the activity of the drug, how it works. So do you really need to maintain high concentrations? And again, this really comes into play with drugs that have a narrow therapeutic index, so drugs that there's not much wiggle room between what's efficacious and what's toxic. So those are really the drugs that benefit most from polymorphism and genomic dosing up front. There's several alleles that we don't even see. They exist. Those polymorphisms exist, but the actual representation in the environment, in the population, is so low that we're not likely to encounter those patients in any degree of normalcy. So, and again, there's some that are just not clinically relevant, because either drugs aren't metabolized through that pathway, or they are metabolized through that pathway, but you have so much wiggle room between the dose it takes to be efficacious and toxic that, altering a dose based on a patient's polymorphism will just cost you extra money and not provide anything of a clinical benefit. But for those drugs that have been identified as drugs with a narrow therapeutic index or requiring proactive individualization, these are usually drugs that are extensively and exclusively metabolized by a polymorphic enzyme. And again, they have that narrow therapeutic index that I keep speaking of. And there are also drugs that have defined concentration response relationships. So I've just listed some here. I can tell you that, the last three I have, warfarin, voriconazole, and 6-MP are probably the most researched, but the other four are, which obviously we're going to encounter a lot with our GVHD prophylaxis, are probably the areas that we'll see in the coming future. So, I kept it broad on purpose. I did mention some medications, but it was really more of an overview than a drug-specific discussion for all the different special populations. But I will answer any questions if you have them. And of course, when you get one of those special patients or a patient that falls in that special category, just keep calm and call your pharmacist.
Hello?
Yes.
I was interested in the comment you made about the attending physicians writing their chemo on the paper.
Yes.
What was the process of that evolution? Did you start that way, or did it change?
No, yeah, it was actually a lack of evolution, I guess you could say. So that's just historically how it's been. Prior to the days of CPOE, they wrote all of the chemotherapy orders on paper, and then interestingly, our hemoc side has totally beaconized, so the physicians enter everything through a treatment plan, but the BMT attending physicians have just decided that's just not the way they would like to practice, that this system works well for them, and so that's the way we're continuing to practice. Mm-hmm. Anyone else? All right, well, thank you guys very much, and I hope everyone gets home safely.